Good afternoon. My name is Beau Hawkins, and within this session on endovascular complications, I've been asked to speak about perforations. This first case is a 69-year-old male who presented with a non-healing right foot wound. Of note, he had undergone amputations of his second and third toes about 6 weeks prior at an outside hospital. He had relevant comorbidities, including diabetes as well as coronary artery disease, and had undergone prior bypass grafting. Additionally, he had chronic kidney disease with a baseline creatinine of around 1.8 to 2.0. He was on appropriate medicines for his history of peripheral artery disease. He did smoke in the past, but no longer, and is currently retired from truck driving. Of note, at the outside hospital, he had undergone an attempt to open an occluded right anterior tibial artery, both through an antegrade as well as retrograde approach. That was unsuccessful. And at that same time, he also underwent angioplasty of his right posterior tibial artery. Here's what his foot looked like when he came to presentation to our facility. You can see he has kind of this non-healing wound bed, as well as a lateral distal kind of necrotic looking ulcer as well. We brought him to the angiographic suite and performed an angiogram. This is us looking at his right leg, and you can see that basically all of his tibials were bad. He had a proximal anterior tibial occlusion that reconstituted fairly distally, several centimeters above the ankle joint. Additionally, he had a tight perineal stenosis, as well as an occluded posterior tibial. You see it proximally here, and it also reconstitutes through collaterals, predominantly off the perineal branch down distally near the ankle joint level. Based on this, we elected to go ahead and start with the posterior tibial artery recanalization, so we were able to pretty easily cross this with a standard 14,000th inch hydrophilic wire. As we usually do, we did IVUS for sizing and then did angioplasty with 2 followed by 2.5 millimeter balloons. You can see here the end result was satisfactory with a couple of areas of 20-30% residual, but no evidence of any flow-limiting dissection and good inline flow through the PT down to the foot. Thereafter, we elected to go ahead and treat the perineal as well. As we said, this was just a stenosis, so we crossed this relatively easily in IVUS. You can see here measures about 2 to 2.5 millimeters. So we started with a 2 millimeter balloon and did angioplasty, and you can see here's where we started to have a problem. Within the mid to distal segment of the lesion, there was a focal perforation. You can see this mushroom or this cloud here. And that was a bit surprising because we were at worst a little bit undersized, but no more than 1-to-1 size based on our angioplasty result. So we did the usual things here. We did prolonged balloon dilatation across the site of perforation. We did the first inflation for 10 minutes. The ACT was checked while we were up, and it was found to be less than 200. We repeated an angiogram and still did not have resolution of the perforation. So we did another prolonged balloon inflation of 15 minutes this time. That still did not work. We still had a leak. And then finally, we actually withdrew the balloon back here, went with a bigger balloon, and balloon dilated the popliteal to cease flow cessation into all the tibials. And again, that did not work. We still had a leak. So after about an hour of doing this, we still had a rupture of our perineal. We felt that we were going to go ahead and have to stent this to get resolution. So we tried to deliver standard coronary covered stent, and it unfortunately would not cross to the area to cover the perforation adequately. And it seems like we got down to about 1 centimeter above, and there was either a rigid bend in the vessel at this point, or there was a lot of calcification that we did not appreciate angiographically. So we struggled, still could not deliver. We put a buddy wire next to this, still could not deliver the stent. And so ultimately withdrew the stent and then elected above this area of perforation to go ahead and try to do cutting balloon angioplasty. We did cutting balloon angioplasty, re-attempted to deliver this stent, and it would not cross. So ultimately what we did in this scenario was we introduced an orbital atherectomy catheter, did atherectomy across this area where the stent would not deliver, and then following that we were able to stent in place. We dilated it to nominal pressure. You can see it's very underexpanded. Took quite a bit of post dilation to get it to expand, but it finally did. and this was our end result here. So we had successful sealing of the perforation, good inline flow now through the perineal. You can see the initial PT work that we did. Now we're left with recoil and residual dissection. We had to go back and work on that just briefly to get that looking better. End result was good with good flow now through the perineal PT down to the foot. This gentleman did well, went on to heal his amputation site, and he's done well now, about 18 months post-procedure. Second case is a 64-year-old male who presented to us with a necrotic right third toe. He had the usual comorbidities of hypertension, hyperlipidemia, was on good medicines for his peripheral artery disease. He unfortunately continued to smoke. His non-invasive studies showed an ABI on the right side of 0.45, and waveforms were consistent with femoral popliteal disease. We brought him to the lab, and this is what we saw. He has a popliteal occlusion starting just above the knee joint level and extending all the way down through the entire course of the popliteal and involving the proximal tibial vessels. The vessels we were able to see down below included the anterior tibial as well as some of the perineal. As we worked our way down further, you can see that the perineal seemed to be the most robust of the three tibials down to the ankle joint level. And so based on this, we elected to start with an integrated approach. Here we actually used a crossing catheter. You can see a whiff of it at the top of this screen. With this crossing catheter, we were able to work down through most of the popliteal occlusion, but could not get through the distal pop down into a tibial. The patient had quite a bit of pain while we were doing this, and so we were obviously naturally concerned. So we withdrew the equipment, did a small angiogram. You can see here we have a pretty sizable rupture of the distal popliteal. To treat this, we took a blood pressure cuff parked here around his popliteal fossa. We inflated it to suprasystolic pressures, left it up for about 10 minutes, did not reverse his anticoagulation, and then we repeated. After that simple maneuver, we had successfully been able to seal the perforation. Thereafter, we went to a kind of standard wire with a support catheter crossing technique with a 14 hydrophilic wire and some coronary CTO wires. We were ultimately able to traverse this. Once we traversed it, the rest was relatively straightforward. We did angioplasty followed by drug-coated balloon angioplasty across the popliteal, and then we had to do some work on the perineal as well. But in the end, we were able to successfully restore inline flow through the popliteal down into the perineal. We did not worry about the AT or posterior tibial at this point, given the issues that we had. This patient went on to do well. He received a toe amputation the following day and successfully healed. Thank you.